Okay, good morning, everybody. I see it's 10 o'clock. We'll kick off this session. My name's Rob Baird. I am the CAPS chair of the Trauma Committee, and it gives me great pleasure to sort of kick off this session. And I guess we heard a few days ago a really important and simple fact that I think will bring this session to light, and that is the massive difference in gun violence between the American and the Canadian pediatric environment. You know, it's a semi-permeable membrane. People are going back and forth. Today we're going to explore some of the system differences between the two countries. And to do that, I'm pleased to introduce a panel that's made up of the CAPS Trauma Committee and the APSA Trauma Committee. So in no particular order, Dr. Dingledine over there on the end, Dr. Baudin, Dr. Williams, Dr. Emer, Dr. Stylianos, and Dr. Ramjes, who's going to kick us off and tell us a bit about the history of Canadian pediatric trauma.
Thanks very much, Rob. Good morning, everyone. My name is Josh Ramjes. I'm a pediatric surgeon and the trauma medical co-director at the Hospital for Sick Children in Toronto. It's an honor to be here and really to share the stage with some of my heroes in pediatric trauma. The theme that I'd like to bring up as I talk about the history of trauma within Canada is that of collaboration. And I think we'll see this in a few different manifestations. So when we think about the earliest 20th century, in the early 1900s, you can see here that what was happening in Canada mirrored really what was happening south of the border in the United States. And there was, as Rob's pointed out, the semi-permeable membrane of ideas. And so Dr. Lawrence Bruce Robertson brought from his time in New York the idea of indirect blood transfusion. Other significant developments early on was the formation of the Canadian Pediatric Society, and that pediatrics was formally recognized as a medical specialty. And in many ways, this would mirror what you'd see in the U.S. But again, that central idea of collaboration and the transition and transmission of ideas is really a central tenet. In Toronto, similarly, as we move into the mid-20th century, this was really the first paper and the landmark paper in terms of non-operative management for splenic injuries, something that would evolve really from the 1950s, 1960s to what our present-day guidelines look like. And again, we see the idea of that being shared in a cross-border fashion, where in 1971, that was presented at APSA, at that time in sunny Bermuda. But again, similar ideas that were shared. So even though it may have been a Canadian idea or a Canadian approach, it was still at an American meeting that it was presented. And so that story of what was happening in Toronto continued to play out. And it would not be a trauma presentation if we didn't include an Inism, where he said preservation of a spleen after blunt trauma should not be in formalin, but instead in a peritoneal cavity. Again, at an APSA meeting. And then we could see the subsequent papers that would come out from Toronto about what the effects of non-operative management are. And from this paper here, I just highlight the length of stay that these patients had with a mean of 14 days. You can imagine that if you showed that on one of your TQIP reports, your administrators would be knocking on your door. So we may have evolved slightly from the 70s. But what we really want to talk about is the trauma system. And so the trauma system within Canada first originated out of Manitoba, and that was from Dr. Charles Burns. And he conceptualized the idea of a regionalized trauma system within Winnipeg, borrowing from ideas that, again, he learned from his time in Baltimore. And it would mirror, and when he proposed it, set it up in a similar fashion to what would be happening south of the border. Similarly, in terms of establishing the first trauma registry, that also occurred in Winnipeg. And so this is from his paper in 1978, outlining what the trauma system might look like, or what he envisioned it would entail. He also was one of the founding members of TAC, the Trauma Association of Canada, which would form in 1983. And what I'd like to highlight here is, again, collaboration with a pediatric surgeon, Dave Wesson from Toronto. So we've seen collaboration now between Canada and the United States, and now this collaboration that existed between our adult surgeons as well as our pediatric surgeons. And so as would follow suit, we see in Ontario and Quebec the development of consolidated oversight of the trauma care that's delivered both at the adult as well as at the pediatric sites. the same would happen in Quebec. And then in years to follow, that would happen across Canada at a provincial or at a regional level. And so the final point of collaboration I'd like to bring up is something that's a little bit more unique in Canada, which is the collaboration that exists between surgeons and emergency medicine physicians. So the Canadian Hospital Injury Reporting Prevention Program, which really started and launched in the 1990s, has been and evolved through a collaborative effort between both surgeons as well as emergency medicine physicians in order to truly reduce the rate of injuries. And we've seen it through the various initiatives that have been championed through CHIRP and the rollout throughout. So, I think present times, I'm fortunate to live in a household of both Canadians and Americans. There is this interplay of ideas that has often happened, and I think it's important to remember that that's been true as our trauma systems have developed. So with that, I'll turn it to Dr. Stelianos.
Well, good morning. Josh, thank you. That was great. And as I was looking at papers that I could recite to you word for word from sick kids and the impact they had on my career, very nostalgic. The final morning of the APSA annual meeting allows us to identify the true believers. And for all of you who are here this morning, thanks for joining us. We really appreciate it. So I'm going to go past, and I'm going to go south of the border. I'm not going to go too far in the past. I wondered where I fit in on the spectrum of evolution here in trauma. I certainly had my heroes, and I look to all of you as being the future heroes of pediatric trauma. I thought this one, somehow it looked like the future was going to walk off the cliff, and I said, this doesn't seem right, so I'm going to go with this one instead, and I'm going to think maybe I'm this guy over here. Maybe. I don't know. We'll see. In the U.S., major progress in trauma care usually followed a war, and the surgeons came back from the battlefield, and they brought back the most courageous strategies to try to save young people who were in harm's way. But the government helped also, and one of the most important recent publications was from the Institute of Medicine. This is a precursor. This is in the mid-60s from the National Academy of Sciences, and it spoke. The title is very powerful, though, isn't it? Accidental Death and Disability, the Neglected Disease of Modern Society. Some of us as trauma surgeons now in 2025 still think this title is accurate, that we're just not paying enough attention to trauma. But this made an impact, and it spoke to preventable deaths. And I think that was really the origin of that term, certainly in the trauma community. And that hurts when you hear about preventable death. So what could we do about it? We could improve all aspects of care, pre-hospital, acute care, rehab, and so on. An emphasis on research and additional funding. The funding that came along with this report was the National Highway Traffic and Safety Association and the implementation of seatbelts. And what a difference, obviously, that has made. So what really the past is about is the transition from trauma centers, individual locations with individual rock stars who knew what to do, to a more global, inclusive philosophy around trauma care. And so that's what the past is about. It's a transition from individual centers to systems. But again, the origins are where? It's military surgeons coming back from Korea, coming back from Vietnam, and bringing skills with them. Funding, that was very, very important. The initial metric, remember, was mortality. Can we improve mortality? And we all know in pediatric trauma care that really doesn't explain what it is we do and the value that we offer. We offer much more value than reducing mortality by a percentage point or two. And the other metrics come into play, return to function, cost, etc. So in the 70s, the word system started to percolate through. Books were written, approaches were taken, and it was just starting to spread through the country. Again, there were centers, I don't mean to exclude anyone from this, but there were centers that, you know, the leaders would come to APSA and get to the podium, and that's when, and speak about trauma, and that's when everybody would go to the restroom or go freshen their coffee or go to the tennis tournaments and golf tournaments we used to have at APSA, no longer. They didn't stay for the trauma papers, or they put them in the corner somewhere where, you know, nobody could find the trauma thing. Things have improved. And then the major issue was EMS for children, and I'm going to get to that in a second. I do want to highlight a few of my heroes. I could have put 20 more people on this slide, but J. Alex Haller was the chief at Hopkins in Baltimore, and Marty Eichelberger was the Pope of trauma, very timely now, the Pope of pediatric trauma at DC Children's. And maybe because they were close to Washington or in Washington, that they really had such great influence on what was to come. But I want to highlight Barbara Barlow because she came from the city and the university where I spent most of my career. And Dr. Barlow is a great example of how, yes, systems are required, but there is still a place for a rock star. And Dr. Barlow was the chief of surgery at Harlem Hospital, and she just was getting children day in and day out that were falling out of 6-story windows and so on. And she said, you know, kids can't fly. And she made it her life's mission to do things for the children of the worst parts of New York City, both with window guards and playground rehabilitation. So hats off to Dr. Barlow. And she was the founder of Injury Free Coalition for Children. I mean, she really took this very, very far. This is a paper no one speaks about, but it was really Max Remenofsky when he was in Alabama at the time who came out with a major tome on what you need that's unique to care for children. And very soon after, that was incorporated by the American College of Surgeons Committee on Trauma and led to the standards that we're all used to, all those books that change color every few years. Max had a lot to do with that. And finally, as I mentioned, the most important transition point in the U.S. Was the formation by U.S. Congress, the funding of emergency medical services for children, specifically for children. And you can read there what an optimal pediatric trauma system is supposed to be. It looks very, I mean, we could still use that outline to help us get there. This was rolled out in 4 states and then just spread across the country. APSA was a beneficiary from this. I was very proud to co-PI with Keith Oldham a grant that we successfully got awarded to APSA for $1 million to look at pediatric trauma outcomes. Again, a shift in attention to not just individual centers saying what they do well, but all of us as an organization could come up front and say what we do well. And I'll finish with this. As we look back now on the early beginnings of trauma systems, you can see that by 1995, there were 22 states. So it went from 4 states to 22 states with a very appreciable reduction in mortality. This is adults and children. And Chuck Paitis, who was one of the young proteges of Dr. Haller, when he wrote this up on pediatric trauma systems, it's a very important quote that we actually have to take with us, which is that one non-negotiable principle must be that any emergency medical system that includes children must use the best and most experienced pediatric specialists. And that's all of us. That's on us to take home, to be advocates, to get involved in state planning, and to make sure that children get what they deserve. So on that note, we'll get into my little private plane there and on to the present. Thank you very much.
So my name's Gil. I'm a trauma director at CHIO, which is only 2 hours from here. And I wanted to talk to you today about some of the present challenges that we have in trauma care in Canada, what we're doing about it at the moment, and then we'll hand off to the rest of the crew. So everybody knows about the golden hour in pediatric trauma and trauma in general. Much like the United States and Canada, about 65% of Canadian children live within 1 hour of a trauma center that's specific to pediatric patients, so a pediatric trauma center. We know that if they arrive within that hour, they have a shorter length of stay, and there's similar results in the United States. The challenge for us is, as we've heard, our trauma volumes are a fair amount lower. Penetrating trauma is quite rare in Canada. I can count on, I don't need more than my 2 hands to count the number of penetrating traumas I've seen in the last 5 years. So the other question is how do we deal with the other 35% that don't live within an hour or may live hours and hours away from the trauma center? What can we do to improve the care before they arrive at our center, or maybe even not have them make that trip down to see us? So I wanted to highlight that with 2 stories. I want you to take a look at this map. That black bar is my catchment area for my hospital. We are the trauma center all the way to the northern tip of Baffin Island across from Greenland. And I'll tell you about 2 patients. First is a 9-year-old female who was riding an ATV and struck their head with loss of consciousness. They live on that little yellow diamond at the top of the blue Ontario. The other one is a 12-year-old who was shot with a pellet gun in the neck. They live in Grise Fjord. That's the diamond way at the top. How are we going to take care of them? Let's start with our ATV collision. They've presented to Attawapiskat Hospital after an ATV accident. Their GCS is now 9 to 10. We're really lucky today. There happens to be a family doctor and a pediatrician visiting from another city. They're the only 2 doctors available to us. They've done an X-ray of the chest and neck. They look okay. They have a CBC and electrolytes, which are normal. We've now run out of other modalities of tests. They don't have ultrasound. They don't have CT. They don't even have any more blood work. We need to get them out. The airport's gravel. We can't get a jet in there, so we have to fly in with a helicopter. A helicopter's going to pick them up and fly them to Moose Factory, where a fixed wing is going to meet them and fly them out. How do we support these physicians? Or if they hadn't been there, how do we support the nurses to take care of this patient until we can get them out? Travel time to Ottawa is 6 to 8 hours, if the weather's good. It happens that it's not the winter, so the ice road is closed. So if they're socked in, they're stuck. They have to wait. Let's talk about the pellet gun injury. Our patients in Grise Fjord Health Centre, they have 2 registered nurses available. There's no advanced practice provider. The injuries to the neck, it's zone 2. There's no pulsatile bleeding, no changes in the voice. So we're lucky. But it's going to be, it's about 950 miles or 1,500 kilometers by air to evacuate from Grise Fjord to Iqaluit, that green triangle. There they can do imaging. They get an ultrasound. The pediatric radiologists at my center read that ultrasound. And they tell me there's no hematoma. There's no sign of vascular or airway injury. Should they continue the additional 2,100 kilometers down to my center to get to the pediatric trauma center, that's a total travel distance equivalent to Montreal to Los Angeles. It's going to take at least another 12 hours for them to arrive. Can we leave them there, or do they need to come down? So, how do we take care of them? First and most important is outreach and education, making sure that the small centers that see these patients have the ability to gain the knowledge to take care of pediatric trauma, because when it happens, it's a halo event, high acuity, low occurrence, and you can't learn from practice. You have to learn through simulation and education. We have to think about support through IT systems, telephone networks to organize transfer, video calling to help assess the patient, to provide advice with real-time visualization of what does the patient actually look like, and understanding the limitations and resources that the centers may have. Training and simulation. We're going to talk a little bit more about assessment of pediatric readiness for trauma and giving feedback to the center that referred them. Once the patient comes down, you've assessed them, taken care of them, and sent them home. So what we do at my center is every patient that's transferred from out of center to our center, when the patient is discharged, we send a feedback form with, this is what we found, this is what we did, we've identified this shortfall in your care, we've identified this excellent treatment that you gave. Please share it amongst your institution. How are we going to do quality improvement beyond that? There's trauma quality improvement program and other risk-adjusted metrics, but they're expensive. You need data entry. You're looking at $15,000 US, which is about $1 million Canadian. Exaggerating a bit. Does that significant cost show improvement? Does it show improvement at your institution? There's evidence that it does show improvement, but let's prove it that it's to the administrators that it's going to work for us too. Will combining accreditation standards help reduce that cost, broaden how we get accredited? There's a significant overlap between the American Burn Academy and the American College of Surgeons accreditation standards. And the other thing is that the Trauma Association of Canada no longer does accreditation. The volumes were too low, the costs were too high, so the only route we now have is through the American College of Surgeons. There's the CPTR, which is a national monthly trauma rounds for pediatric care that anyone can join. Invited speakers from around the world. We've had speakers from the UK, Lithuania, and across Canada and the United States in the last 6 months. It's a great way to reach out, promote education and networking. Continuing medical education with trauma rounds. The regional trauma networks that we have. So every center, every pediatric center in Canada has a defined region, a defined catchment area. And we are the primary trauma center, but we reach out to our referring centers. We provide education. And then trauma simulation. Because if you're doing a handful of penetrating traumas a year, you can't rely on institutional experience. You need to build that experience with simulation. And then TRIC, which Dr. Baudin will be talking about in a few minutes. Dr. Williams.
Good morning, everyone. I'm going to briefly talk a little bit about the present system of trauma care in the U.S., and I'm really going to focus on epidemiology access and then a national pediatric trauma system. So Rob has already mentioned, but there are some extreme differences between the U.S. and Canada as it pertains to epidemiology of trauma patients. And so, as you should all know, but if you don't, I love the CDC chart because everything in blues. The top causes of death in children is all injury. And so we spent a lot of time learning about wonderful topics this week at APSA. But remember, if you want to have the greatest bang for your buck, you should study trauma and how to make trauma, how to make patients safer and how to make those outcomes better, because that's where we're going to have the most effect. The other thing that was mentioned, and there was a great presentation yesterday that really fully talked about the difference in penetrating injury in the U.S. and Canada. And we've all seen this chart that's to your right, but firearm injuries became the leading cause of death for children in 2020. And so if we really, really want to focus on how do we save lives and those preventable deaths in children, it really is going to focus on injury prevention for firearms in our country. There was a wonderful study a few years back that looked at differences between Canada and U.S. when we talk about fatal traumas. And you can see that in Table 1. And so you can see that motor vehicle collisions were the top cause, and that was pretty similar. And this is between a center in Missouri and then one other center in Canada, which was in Ontario. I'm really terrible on geography, so I can't remember those things. But you'll see next is the great difference between firearm injuries and fatal mechanisms. It was so much higher in Missouri versus Canada. And then the third one is drowning. And so we see a flip here. And when I was getting ready for this talk, I was really surprised on drownings being, the number 2 cause of fatal trauma deaths in Canada. And then my partners here told me there's a lot of water in Canada, and that's different in the United States. And I thought that was pretty interesting, but definitely a difference in our epidemiology. And then when you look on the study on the right, this is just talking about case fatality, and the 2 injury patterns that have the highest case fatality in Canada are actually self-harm and drowning. And so that is split for the United States. Our highest case fatality rate is firearms. Next, I just want to talk a little bit about access, and Gil did a great job talking about that large landmass of Canada and how many pediatric trauma centers they have. And so if you look here, you can see in the bottom left is all hospitals. We have a ton of hospitals in the United States, but not all of those hospitals can provide care to children, and certainly not all of them can provide adequate trauma care to children. So if you look at the top right, those are all the level 1 and level 2 pediatric trauma centers are located. And you can see there's a lot of clustering in the Midwest and the East Coast, and then a little bit in the West Coast. But we do still have a large landmass in the middle there that doesn't have access to pediatric trauma care. And so though that's not where most of the children live in the United States, we have an interesting system because we have lots of regions that have a ton of trauma centers, and where most of the children live within an hour of a pediatric trauma center. But then we have that area out west where most of the children do not live within an hour of a pediatric trauma center. And these other slides are just for your information. Burn care is even more fragmented than trauma care, so there are even fewer pediatric burn centers in the country. And then you can see we do have a large number of level 3 and 4 adult and pediatric trauma centers, and it's really those level 3 and 4 centers where we can focus our education on making sure that they can adequately care for, or at least get the process started on taking care of pediatric trauma children, and then getting them to a level 1 or 2 center if that's what they need. Next, I'm just going to briefly talk about the 2006 Institute of Medicine report. And I know that y'all have seen these slides before, and I want to give a big thanks to Mary Fallett, who let me borrow some of her slides, because she has really been doing this work for about 20 years or so, and is going to continue to organize our pediatric trauma system in the years to come. But based on this Institute of Medicine report, we found that most children in the United States weren't getting good care. And that's because most of the emergency rooms that you saw on that previous slide don't have the equipment necessary to take care of children, and frankly are really scared when a child shows up to their emergency room. And so how do we get them prepared to at least accept the child and get things started and get them to where they need? This led to 2, well, thank you. I have the nicest panel, y'all. Trauma surgeons are the nicest of all the surgeons in APSA, just in case you were curious. Pediatric surgeons are really, really nice people in general, but pediatric trauma surgeons, they're the best. So the Institute of Medicine report led to 2 summits that were sponsored by the Children's Foundation. And you can see this is one in 2013 and then one a few years later. And what came out of those summits was just like, what is the state of pediatric trauma in the United States? And then what do we do about it? And how do we make it better? And you can see I love this graphic because it just talks about the different aspects of a pediatric trauma system. And so what happened next? Well, Mary got together and did an assessment. So she came up with a pediatric trauma system that was really based on that second Children's Summit, and had a scoring system where she assessed every single state and all of the trauma centers and hospitals to just see how ready they were. And these numbers are really small and they're not really meant for you to look at them. But there is a great article about how you assess for pediatric trauma in the United States and then how all your states are doing. I, of course, wanted to know where my state is. I'm from Memphis. Tennessee's actually pretty good. Our score is 85. These scores have actually been linked to mortality. So states that have a higher pediatric trauma assessment score really do have lower mortality. And that means that a lot of the aspects that are being questioned are really pretty important. And I, of course, don't have time to go into that, but if you want to look up the article, you can see what all the aspects of that are. And then also, if you ever have Mary Fallett talking, you should go listen, because there's a whole plan as to where we go next and how do we make things better and how do we improve access and pre-hospital care, and then also, the long-term things that are really important for our children that are not surviving for 5 to 10 years, but are going to survive for 50 to 60 years. And with that, we'll go on to the future.
Bonjour tout le monde, Marianne Bourdin du CHU Sainte-Justine à Montréal. So given the fact there are very few pediatric hospitals in Canada, ensuring pediatric readiness across all centers is something that we really need to focus on in the future. In Canada, 85% of pediatric emergency visits are in non-pediatric centers, and 1 in 4 children with major trauma do not receive care in a pediatric trauma center. Pediatric readiness is a concept that came up around 2012 in the USA with the National Pediatric Readiness Project. It's a score on 100 points that look at 6 different categories and then assess the pediatric readiness in each centers. Like Reagan said, it's been demonstrated to correlate with outcomes. In Canada, there are very few studies looking at pediatric readiness. A study from Alberta showed that the score was 48.4 in general EDs, while there was another one more recently in Manitoba that showed that the score in general EDs was 52.3. Just remember, it's over 100 in the general EDs and 89.7 in the only pediatric center of the province. So when we talk about pediatric readiness, the first thing we look at is survival. But pediatric readiness can also involve other aspects. It's becoming increasingly popular to look at low-value care. And we all know that children who are treated in pediatric trauma centers are treated differently in regards as exam and procedures that are being done to them. So being pediatric ready can also imply restraining the use of CT scans, for example. This is a Canadian study that was published just recently that looks specifically at low-value practices across the Quebec Trauma Network. And examples of low-value practices are performing CT scans in patients that are scoring low on the PCARN head CT rule and admitting all patients with a minor head injury. So these are practices that we can look in a trauma network and try to do de-implementation strategies to make sure that we're not over-treating children that are seen in non-pediatric centers. There are multiple initiatives in Canada to improve pediatric readiness in non-pediatric trauma center. One of these is TREC, which is a platform that's web-based that shares evidence-based practices in pediatrics. And there are several topics in trauma. So the things you can find on the website, there are tools such as algorithms to manage patients with major trauma. These are checklists that you can use prior to getting your patient in your center and also prior to transferring to pediatric trauma center. And these are order sets that contains all the medication with the correct doses, and all of this has been reviewed by a committee and is all evidence-based. Another thing that we developed was a course. So it was developed in Canada in 2015 by a group of Canadian physicians. It's a pediatric trauma course that's simulation-based, and it's now being hosted in Canada and US, and it's virtual and in person, and it's a really nice course. While the TRIC course is excellent, the number of participants is fairly limited, and it's also very expensive to run. This pediatric trauma virtual reality trainer was developed at McGill University by my colleagues just on the other side of the mountain. It can make it easier to do outreach programs and also in a global context if you want to try to train centers that are in the third world countries. I think we have time for just a quick videos.
Lots of deaths could be prevented if the health providers had better training.
And pediatric surgeons at McGill University have come up with a way to offer it.
So this is apparently a 4-year-old that was involved in a...
It's called Petite VR, a virtual ER, where all the patients are injured kids.
So this patient is bleeding inside the abdomen.
Right.
No expensive medical mannequins, travel, or courses. This training can be done anywhere, anytime.
If you want to know more, there's a website if you want to look at it. In order to improve pediatric readiness, it's very important for the PTCs to act as leaders and guide the other centers. In a mature trauma system, all the centers should be working together. In the province of Quebec, there are 3 PTCs that all have their designated referral centers with signed contracts. This helps identify the criteria to transfer to a pediatric trauma center, as this is part of the contract, but also the key players at each institution to ensure partnership. The PTC is then responsible for education and outreach to their designated center. Example of initiatives our center has done is 24/24 access to a pediatric trauma coordinator to help just treat the patient outside and also make sure that the transfers go smoothly. We have been participating in local trauma conferences, and we provide tools such as just-in-time training like that on our website for centers to consult when they get pediatric trauma patients. There's also been other initiatives for tele-resus in Canada at McMaster and Nova Scotia so that they have a camera in their referral center's trauma room and they can help guide live resuscitation of pediatric trauma patients. And that concludes my talk.
Thanks, Marianne. That was great. And thanks, everyone, for being here. We appreciate it. We thank you for taking the time on Saturday morning. I volunteered to talk about the future of pediatric trauma systems in the U.S. At the time I volunteered, it seemed like a great idea. And I started thinking about the topic, and it seemed incredibly daunting to me. And trying to pull some sort of data or literature, figure out what are we going to actually talk about. So I went back, and many of my colleagues on the panel have already spoken to this in better detail, but I wanted to think about first, what are the challenges? And then based on those challenges, how can we actually innovate and attempt to maybe predict the future? So what are the challenges? So we talked about fragmented, uneven trauma system development. Geographic access to pediatric trauma centers is highly variable in the United States. Pediatric readiness, emergency departments, and EMS. Others on the panel already talked about this at length, but this is a fantastic concept, and this is really going to drive the future too. Workforce constraints. What is the future of pediatric surgery training? And then unclear future of federal support. I get part of my funding, my salary support from part of the EMSC. And as Dr. Stelianos highlighted, this is one of the major things that really impacted trauma care in the United States. And if you're following the news, it's one of the things that's being threatened to be cut. So what does the future hold? Well, I kind of decided to put it into 3 big buckets of areas. One is the expansion and extension of expertise. How do we move beyond just what we're doing? How do we standardize care, making sure that all kids are getting the same high-quality care? And then standardization of trauma center and system design. So what do I mean by that expansion and extension of expertise? Well, pediatric readiness, like we talked about, but going beyond pediatric readiness and expanding this not just to maybe adult trauma centers that don't take care of kids as often and making sure they can, but expand to other areas such as pre-hospital pediatric readiness and expanding into the concept of disaster readiness too. I didn't put the literature in here, but 40% of all disaster planning scenarios in states across the U.S. do not include a pediatric scenario, right? We are not prepared for pediatric mass casualty. Telemedicine. This is going to be huge. And I highlight the fantastic work that the Utah group has done in really trying to expand out their expertise to other centers around their state and in their region so kids don't have to make those long distance travels. This is going to be incredibly important in the future. And then AI assistance. As we heard Dr. Powell talk about earlier this week, one of the futures of education within APSA is the AI augmented search engines for APSA. We all know how much this has changed kind of our lives in the last 3 to 5 years. Just think about over the next 20 years, the ability of having augmented assistance from computer systems, not just for you to help make real-time decisions, but again, your colleagues that are maybe at a critical access hospital facing a sick kid. This paper I highlighted down, I found fascinating, which is really just looking at it's a DeepSeek model, looking at the ability for the computer system to identify traumatic brain injuries relative to the radiologist, and the computer did significantly better than the radiologist did. Standardization of care. I mean, it's robust research networks. It's pulling together all these really smart minds and high numbers of patients to figure out what really should we be doing for this care. And then having standardized quality improvement, making sure that we're actually doing the things that we want to do, and that using a scientific-based method in that quality improvement process. Standardization of trauma system and design. We have to have federal support, federal funding, federal backing for a national trauma system. Right? We have to make sure that we leverage the things that we know in trauma system design to impact kids. And this goes to systems we already in place, like through the Committee of Trauma, ACS, where we know if we make little changes, that can have been big ripple impact through the system and really change how people are affecting care. Example of that goes back again to pediatric readiness, where in the Gray Book, the most recent standards from the Committee of Trauma actually includes a standard around pediatric readiness. Our marks part talking about that regional trauma system. And a big push from the ACS and others right now is the development of what we call regional medical operating coordinating centers. These are actually having regional centers of really excellence in coordinating, knowing where patients go and how to treat them, but also this helps extend that expertise. And this is already being implemented in multiple places across the country, probably most effectively now in Washington State. We have to be the advocates, right? We are the experts. We need to get in front of our elected officials and advocate for why this is an important topic. We've seen this slide many, many times, but highlighting, yes, firearm-related injuries as the major cause of death in the United States, but also all these other things. Like, we have to be able to get in front of our elected officials. The workforce constraints I mentioned. How do we expand the number of experts, right? We can't rely just on the pediatric surgeons. It's making sure that, yes, our fantastic colleagues in pediatric emergency medicine are well educated in trauma, but even their numbers are relatively limited. It's also making sure that our adult trauma colleagues, our adult emergency medicine colleagues, the family medicine docs, the PAs, the others that are staffing these critical access hospitals know how to take care of kids. PECS, which is part of the emergency readiness concept. PEC is a pediatric emergency care coordinator. That means one of the most important things about pediatric readiness, right? What really improves your scores is just putting one person in charge in your hospital to say, you're in charge of now making sure that we are ready for kids, that we have the equipment, that we have the guidelines, et cetera. It makes a huge difference. Making sure as a level one pediatric trauma center that you truly are developing the partnerships that you need to expand out your knowledge and expertise, again, like that Utah model. And again, going back to diversified training models, making sure that we're properly educating our adult trauma colleagues, emergency medicine, others in pediatric care. So in summary, the big buckets of things that I was mentioning is the expansion of expertise, the standardization of care, and the standardization of trauma systems is really what I kind of see as the future of trauma care in the United States. And really the future of trauma care in the United States is all the people in this room, right? It's these great collaborations. That's why I highlight all these groups and the great work that's being done, because this is really the future. It's having this incredible momentum of this fantastic group in this room to drive the conversation. Merci.
We do have a few minutes for questions if anybody wants to chat about the future, current state, or the past.
Hi, I'm Michel Lallier from St. Justin. Thank you, everyone. Really nice panel. My question is going to be the question that no American ever will ask. But for my colleague American, what is your solution for the funding? Because everybody talk about the importance of the funding, but with your new administration now and what we hear in Canada, they cut a lot of places. So what is your worry and what's your solution?
Lots of worries, I'd say. But as you see with federal funding, and we've seen from the administration, right, is lots of, it's not even the lack of funds, it's the uncertainty. It's trying to plan for the future. I don't know what the solution is other than making sure that we get in front of those elected officials and try to properly educate them. And at least for the next 3.5 years, also looking for other sources of funding, foundations, et cetera.
I think anytime you start a program or a mission, you need to have rated funding where you're getting money from lots of different areas. And so, though there is a lot of uncertainty with federal funding right now, there is still local funding for programs and research and also across your state. So for me, I kind of took from this meeting, when things look bad, you just focus on what you can control and think about the possibility, and this too will pass.
There are a lot of billionaires in the United States, and unfortunately, the disease that we have devoted our careers to, no one escapes this. No one doesn't have an experience in their community, in their church, in their playing fields of a child who was seriously injured. And so it just may be a shift currently from federal dollars to advocating and making a compelling story for some of the billionaires to unburden them of some of the money that they have to shoulder. There's money there. We just have to be champions for it, and we can get it.
Thank you.
It's a really good question. The other thing I always think of, I'm from Memphis, so St. Jude's there. We just can learn something from St. Jude about how to get money from people to do great work. And I love what Steve said, because nobody wants to see an injured child die before their time. And so I think we have to focus on the things we control and maybe learn a little bit from pediatric cancer on how to raise money.
It's very rare that when I'm watching television, if that's what it's still called, I don't know if it's, I don't know what it is. I'm streaming, I'm dreaming, I'm doing something. But when a commercial comes on for St. Jude's, one, I always have to wipe away a tear. And number two, I say to my wife, I say, wow, that was a good commercial. Well, we can do that too. We have stories to tell. We don't wish this on any of the children that we take care of, but we take care of them, and we can tell their stories and probably get some attention.
Any other questions?
Okay. There we go.
So Mark Walton, I'm from McMaster. Gil highlighted our regionality issues, huge. And I just wanted the panel to sort of weigh into the use of technology. We talked about AI, how it can help. But when we're regionally so dispersed, and I'm sure the same in Canada, in the US, where we have places where there's no cell service in Canada, how do we communicate and support those practitioners that are in rural and remote communities to provide that first basic level of care? Any thoughts about that?
As you mentioned the AI, that's really kind of where I see these AI assistants coming in. And I think when you look at those rural places that don't have immediate phone connection, having the ability for a device to, whether it's a heart attack, a stroke, a kid with trauma, to be able to help you analyze that situation and provide some basic stabilization, I think is going to be really important.
I think just thinking about pediatric readiness and, whoever is there, be that a basic EMT or a nurse, ensuring that they have the basic skills to take care of a child in the beginning. And then, the telemedicine thing, which won't help if you don't have cell service, but the Utah has really done a fantastic job of setting up a pediatric trauma network where they're doing, it sounds like similar to what you're doing, where their radiologists are getting online and reading those films and determining that a lot of those patients don't really need to come to a pediatric trauma center anyway, and they can be safely managed at their home institution. I think in the next few years, we're going to see a lot of that move forward in the United States as we determine how do we get the right care to the right patient at the right time in the right place. And that isn't going to be, traveling miles and hours to get to a pediatric trauma center because that does affect all the rest of the healthcare that's happening when that child is traveling. So I think pediatric readiness is a great thing. I agree with Mike that AI could be helpful. And I think using telemedicine more effectively and more seamlessly as we move forward.
I would just add, in the Canadian context, I think this is where Dr. Moore's work is going to be extremely instrumental. I think understanding what low-value care and what high-value care is going to be will help us create critical access points for the remote areas that are geographically separate. Hopefully that'll give us the ability to force the governments to be able to fund the availability of resources within those areas so that we create the transfer networks that are needed.
You're seeing this a lot with appendicitis. 17-year-olds can't be safely done at a center, and the surgeon is smaller than the patient. I think when we properly support people by being available with information technology, day and night, and having pediatric readiness drives to see that the referral centers are actually ready and have the skills and equipment that's required, then we can start leaving more people in the community safely. And when people feel supported and they have the resources they need, then it becomes easier.
Dear true believers in the audience, I just would appreciate you taking a moment with me to thank our panelists for a terrific, amazing, broad and depth talk. Thank you guys. Terrific work.